Welcome, everyone. Good afternoon. My name is Dr. Susan Upham, and I'm going to be your moderator today. I just want to let you know I'm on the NECOM and MARCOM Educational Committee, and we work on setting up these webinar series. And this is specifically for folks in the OEM field, so we welcome your presence here. I just want to give a mention of our next big webinar that's coming up on July 9th. It's 2 hours on everything bloodborne pathogens, and it's going to be provided by Dr. Nazan and Behrman, and should be an excellent review of everything you need to know with regards to that topic. So I hope you'll consider joining us. So I'd like to move on to our webinar for today. I'm very pleased to introduce to you Dr. Jay Patel, who is a fellowship-trained orthopedic surgeon who specializes in foot and ankle surgery. He's a graduate of the Pennsylvania State University, and he attended medical school at the University of New England College of Osteopathic Medicine. He completed a residency in orthopedic surgery at McLaren Greater Lansing Hospital in Lansing, Michigan. And he then completed his foot and ankle fellowship at the University of Pittsburgh Medical Center. He now works at Excel Orthopedic Specialists in Woburn, Massachusetts, and his interests include lower extremity reconstruction, hindfoot deformities, ankle replacement, foot and ankle trauma, minimally invasive surgeries, and athletic injuries. So with that, I will turn this over to Dr. Patel.
Hi, everyone. So let's get started. We'll kind of talk about just ankle sprain quite a bit in details today. These are the goals, objectives of today's talk. We're going to review the anatomy and biomechanics of the ankle, identify some key clinical features, going into a detailed clinical exam. What are some of the red flags, right? When should you immobilize rather than kind of doing the early rehab that we all do for ankle sprain? When should you refer to orthopedics? We're going to outline step by step how to manage these patients and then talk about possible return to activities. I do not have any disclosures related to this talk. So let's go over the anatomy. Just mainly we'll refer to more ligaments, so we'll kind of keep it more concise. Anatomy of the ankle, ligaments laterally, those are the main important ligaments. You have three ligaments, combination of anterior talofibular ligament. This is the weakest out of your three ligaments. It restrains inversion when the ankle is in plantar flex position. Your calcaneofibular ligament, which restrains inversion more when the ankle is in neutral or dorsiflex position. And then you have a posterior talofibular ligament as well. Medially, you have your deltoid ligament. This has a superficial as well as deep layer. They both prevent valgus tilt. Deep is usually the main stabilizer. The stability of the ankle comes from not just the ligaments, but also the tendons. You have a combination of dynamic and static stabilizers, right? So your dynamic stabilizer becomes more your peroneal tendon, your posterior tibial tendon. Peroneal tendon laterally complements your lateral ligament complex, which is why in rehab, we kind of focus quite a bit on strengthening the peroneal tendon to compensate for the weak ligaments. Medially, you have your posterior tibial tendon that complements your deltoid ligament and prevents valgus tilt and eversion type sprains. And anteriorly, you have an anterior tibial tendon that stabilizes the ankle, particularly when ankle is more in plantar flex position. The mechanism, usually inversion ankle injuries are about 10 times more common than eversion injuries. This happens because the anterior portion of the talus is wider than the posterior portion. So when the ankle is in a little bit of plantar flex position, particularly when someone's going down the stair or getting off a curb, there's a little bit more wiggle room in posteriorly, and the posterior portion of the talus is now articulating at the joint, and there's a little bit more wiggle room, making it more likely to get these sprains. When we talk about these ankle sprains, these are the more quote unquote low ankle sprain, not high ankle sprain. We'll talk about that a little bit in detail, but low ankle sprain, those are the more common. Usually you have your tear if your ATFL is the first one to tear, followed by CFL. The posterior talofibular ligament is pretty strong and it's less likely to tear, but doesn't necessarily play too much role into future, including surgical treatment options. This is a pretty loaded slide, kind of just talks about the different grades of ankle sprain, talking about the ligament injury, the swelling, and how much pain they should have, as well as weight bearing. The grade 3 and A and 3B, those are more radiographic. So those are more kind of considered more on stress x-rays and whatnot. So not necessarily important from an exam standpoint. It's a little bit better slide, kind of summarizing it a little bit, more concise. So if you look at three different grades, grade one is mostly just the stretching of the ligaments. You can have microscopic tearing, but not necessarily any joint instability. They have mild swelling, some pain, but typically able to fully weight bear. Grade two results in more partial ligament tear. They have joint instability as well, but they can have pretty moderate swelling, pain, ecchymosis. And then depending on what it is, they may or may not have a difficulty with weight bearing. Grade three is more of a severe ligament sprain. This can involve complete disruption or rupture of one or more ligaments. They have a pretty decent instability on exam, often significant edema, and they're having pretty much difficult time weight bearing. Some of it is a little bit subjective, right? How do we grade swelling, mild, moderate, severe? It all depends on, what we have seen in clinic, in our practice. Um, and, length of time to return to activities. There are some guidelines about 1 to 2 weeks for grade one, grade two, about 4 to 8 weeks. Grade three can take like 4 to 6 months at times, but it varies quite a bit. Everyone's recovery is different. So I don't necessarily always go by these guidelines as far as how long it should take them, but it's kind of come something that's in back of my mind while they're going through this recovery process. Um, Evaluation, the biggest thing when it comes to evaluating ankles after ankle sprain is where is their pain? Because you need to make sure we palpate the ligaments, lateral ankle ligaments, ligament palpation. The pain with those has about 80 to 90% sensitivity. Palpate the syndesmosis for any high ankle sprain. Look at the medial and lateral malleoli. That would more be indicative of fractures. People with ankle sprain will have some pain at the tip of lateral malleolus, but not necessarily higher up into the distal fibula. Palpate for the anterior process of calcaneus, fifth metatarsal base. Also need to palpate for proximal fibula. This is something we'll talk about in a little bit detail afterwards as well. Fifth metatarsal base, again, same thing. A lot of people have foot fractures from ankle sprains because peroneal tendon pull results in that fracture. There's special tests, your anterior drawer test, and your talus tilt. Most clinicians are usually pretty familiar with that. Anterior drawer test is done when ankle is in about 15 degrees of plantar flexion. You stabilize the tibia and pull from the heel itself. Translation of about 5 millimeters or more compared to contralateral ankle, or absolute translation of about 10 millimeters or a centimeter can be indicative of incompetent ATFL. You can do the anterior drawer test a little bit more in neutral or dorsiflex position, which would more be indicative of CFL injury. Talus tilt, pretty much you hold the ankle more in neutral position and invert the heel. This is done at about 10 degrees of dorsiflexion or neutral to kind of isolate the calcaneofibular ligament. In an acute setting, this is difficult to do, in my opinion, because they're so rigid that they're guarding quite a bit. And in an acute setting, particularly when they have significant sprain, it almost as if they have no instability because they're so rigid, they're guarding quite a bit. They don't let go of their ankle. So it becomes very difficult to evaluate how much laxity they'll have. And I'll just put in my note, patients guarding against ligamentous exam, and that's all completely okay to do. And then, during their next evaluation, when their pain and swelling is better, you can really truly assess how much laxity they have. The infamous Ottawa rules, right? Whether we should obtain imaging or x-rays or not, basically these include four components: inability to weight bear both immediately and after the visit, need any tenderness either at the malleoli, navicular, or the fifth metatarsal base. If they have that, they should get x-rays. In my clinic, from an orthopedic standpoint, we have x-rays here. So anyone who's coming in from an ankle sprain is getting an x-ray. I've seen scenarios. I had a patient who was in
I
Peru,
figured
was
out.
hiking Machu Picchu,
I actually had a free spot until a few more
sprained their
minutes. I was gonna eat
ankle.
something, but
She even finished her hikes and everything as well. And she had some
this is a
pain. She rolled her ankle. She saw me in clinic 10 days after her injury, and she had a lateral malleolus fracture, right? And so there was certainly a stable fracture pattern, did not displace, which is why her pain was not too bad. When you're evaluating them, you want to consider for hind foot alignment as well. People who have high arch, flat foot, if they have high arch in particular, they're at a higher risk of developing instability in the future. When it comes to treatment options, certainly non-operative management is the go-to option. We're currently we're talking about just isolated ankle sprain without any associated injury, and more importantly, low ankle sprain, as we talked about. Start with rest, ice, compression, anti-inflammatory medications, immobilizing, whether it's brace or a boot, depending on their pain level. You gradually increase their activities as pain allows, and followed by physical therapy. Really important to have early appropriate management. If people who do not get adequate early management, they're at risk of developing instability, and up to 40% of the patients without adequate rehab can develop chronic instability. So what's the first line of treatment for these patients? Usually ankle support. There's been a lot of literature. There was a systematic review of 9 studies that looked at the functional management of patients, and they saw that lace-up ankle braces are usually most effective. They looked at taping as well. No difference compared to semi-rigid support, but actually had a higher risk of skin irritation. But in athletes, that becomes important for taping because lace-up ankle braces are sometimes just too difficult to put into cleats. It just becomes too uncomfortable for those kids. Elastic bandages or A straps are least effective. Makes sense, right? They're helping more with swelling control, but they're not really having any sort of rigid stability. Followed by rehab. Typically, patients who have ligament laxity and significant pain, you can consider rigid immobilization, even in a boot for a couple of weeks, or instead of a brace, depending on their pain level. And during that time, you can still have them, take medications, do the whole right situation, and afterwards, making sure that they're working on their range of motion. Goal of return to activities, 6 to 12 weeks, but as I mentioned before, can vary quite a bit, and it's different for everyone. One of
Dr.
the biggest,
Patel? Oh,
yes.
I was just going to ask about these. Go ahead.
Okay, yeah. So when it comes to immobilization, there's no clear-cut guideline. Obviously, we talk about, hey, early rehab is best, but there are plenty of patients who have significant ankle sprains who come into clinic, their crutches, they're not able to put weight on it. It's okay to immobilize them in the boot. For ankle sprain injuries, tall boot is always better than a short boot. I will get a lot of patients coming from, whether it's some urgent cares, which they don't always have tall boots available. And then sometimes some of the whether it's emergency room or urgent care, may feel that they should do something for the patients because they're so painful, right? Otherwise, patients leave, they're dissatisfied. So they'll go in short boot. If they have it, that's like, I don't change it to long boot because that just becomes expensive for patients. Insurances don't cover it. But tall boots always giving you better support. I emphasize, however, that even if you're in the boot, make sure you come out of the boot working on range of motion, right? And you want to transition out of the boot as soon as you can. Try not to do boot any longer than a couple of weeks. If they're needing the boot longer than a couple of weeks, then I do have them come in to, hey, see me in clinic. We'll just reevaluate to see if there is anything else that we should think about here. And then sometimes I'll put them in the boot. Early on, patients are painful everywhere, right? They're painful at the malleoli, the peroneal tendons, the ATF, the ligaments, the heel, Achilles, like you name it, right? So it becomes extremely difficult to evaluate these patients. In that case, again, same thing. I'll put them in the boot. They can put weight on it as you can tolerate it. And then have them come out of boot, regular working on range of motion. I'll see them back in a couple of weeks. And by that time, you'll be impressed as to sometimes their swelling is better, their pain is better, and pain actually starts to localize quite a bit. And ligamentous exam becomes a little bit easier as well. So if they're having generalized pain, that does not necessarily mean we need to jump into MRI. I've heard patients say that, hey, I was told because I have pain on the inside of the ankle, also I need an MRI, and that's not always the case. Boot sometimes actually makes patients feel more secure, and they'll actually start walking on it because they have something helping them. It actually makes them feel more confident, and they'll actually start working out, coming out of the boot as well. So there are definitely good signs and good times where they will benefit from boot immobilization. Looking at the rehab, they have compared functional management versus immobilization. These immobilizations were related more to like cast or prolonged boot immobilization. And they've done a lot of research on it. People who were managed functionally have higher percentage of patients returning to sports, shorter time to return to work. They've had fewer patients, with persistent swelling, fewer patients with increased laxity. These patients also have better range of motion. So functional management clearly has better outcomes. They also have a higher rate of satisfaction than patients who are immobilized. Again, no one really does cast anymore for ankle sprains, but they used to do that quite a bit. So these are also some of the same reasons why we avoid prolonged immobilizations in the boot. And then comes physical therapy. Traditionally focuses on strengthening of the peroneal tendon, the peroneal muscles. We talked about before how peroneal tendons complement your lateral ankle ligaments. So, they're helping with eversion and they prevent inversion injury. So they work on close chain activities, they optimize foot strike and mechanics, and they compensate for the ligaments that are currently healing that are weak right now, right? So peroneal strengthening is becoming important. There's a lot of new literature that's found beneficial of strengthening muscle proximally in the lower extremity. Some studies kind of found that gluteal musculature had a significantly different activity in patients who had a lateral ankle instability. It's kind of suggesting that, hey, we should focus on other areas as well and not just get too focused on the ankle itself. Another study showed that there was patients who engaged in core stability helped improve control of the ankle as well, right? So all of these things kind of describing maybe potential avenues for managing patients with lateral ankle instability. I went to an osteopathic medical school. This is not something I do anymore, but are there any osteopathic treatments that, certainly there's some small studies that have kind of talked about, early on, there's some benefit. These patients, 3-week results showing they have less swelling, better range of motion, and less pain compared to patients who are managed only with medical treatment and not medical and osteopathic treatment. These treatments early on, they focus more on just soft tissue control, swelling control, not much manipulation involved, and later it kind of focuses on strengthening. But I think physical therapy has just shown pretty good benefit overall, and a lot of the times osteopathic treatment may or may not be covered by insurance, so that can play into it as well. This is the difficult part. Okay, when are they ready to return to activities, right? So you need to make sure they regain almost all of their range of motion. You need to make sure they're not having any gait abnormalities. Those are a couple of things that may be easier to evaluate. Want to make sure they're about 80 to 90% of the pre-injury strength, right? We have no idea what their strength was like before, but you always compare to the other side. Some of the things you can have them do in clinic. I'll have patients do a single leg hop test. I'll have them hop up and down on that same leg about 10 times and see if they have any pain. Again, it's a very short period, but at least it tells patients that maybe they're ready to take the impact of the work. You also have work hardening programs. People, particularly if they have strenuous job, they do physical therapy, but we're not sure if they can handle the impact activities that comes with some of the work. And these, if they get approved, they usually do an evaluation. If they get approved, then they can basically, what they try to do is mimic patients' work over a week or multiple weeks and kind of see if they are ready to return to work or not. And as you mentioned before, right, some of the talked about return to activities up to 2 weeks for grade 1, depending on the literature you look at, this kind of varies. Grade 2, 2 to 8 weeks. Grade 3 can be as early as 2 weeks, but can be as long as 4 months. Functional outcomes. If you look at functional outcomes at 1 year mark, whether it was immobilization, physical therapy, their outcomes were actually pretty similar. So why are we emphasizing on they need to have early management? It's because they have had much better outcomes early on. These patients are able to return to work or sports sooner if they're managed earlier. But there's some studies that have shown that at 1 year mark, they're doing about the same regardless of what the management that was chosen. But again, quicker time to return to activities is obviously the goal for most patients. How do we define that, conservative treatment is just not working? There is no firm endpoint, unfortunately, that's been described in literature. From an orthopedic standpoint, we traditionally use 3 to 6 months of, conservative management without any improvement. Again, becomes a little bit subjective. Obviously, we need to worry about some of the associated injuries if we're worried about other things. Are they plateauing in their treatment, right? Is physical therapy actually getting better? I tell patients we're looking for progress and not always resolution. As long as they're making consistent, steady progress, you can continue conservative management, because if they're making progress, we're not going to necessarily jump into surgery. If they're not making progress, if they're getting worse, obviously those are times we should pause and think about other options or what else could be going on. And this is where these other associated injuries can play into it. Some of the reasons why conservative management is not working. These are the things that commonly get missed with ankle sprain. You can have talar cartilage injuries, peroneal tendon injuries. There are associated fractures. Anterior process calcaneus is one of the more common ones. Avulsion fractures are more common. Lateral process of talar is not very common at all, but occasionally you'll see that. But again, it's really not common for these patients. These are the patients going to delay rehab, potentially need to immobilize them in the boot. Again, I do not do cast for these typically, but put them in the tall boot, and depending on what it is, make them non-weight bearing or partial weight bearing, or sometimes full weight bearing, depending on what we see on their exam. Let's go through these injuries step by step. Peroneal tendon injuries, a little bit of higher coincidence, particularly if patients have high arch, so cavo-varus foot. They have a higher risk of developing peroneal tendon injuries with ankle sprain. You have your longus and your brevis tendon that cross the lateral ankle. Again, it functions and supports our lateral ankle ligament and prevents against inversion injuries. These are commonly missed in ankle sprains that are not improving. And then there's multiple different pathologies that kind of come with peroneal tendon. You can have subluxation of the tendon. There's a tendon sheath that covers these two tendons in the retrofibular groove. If you have tears of the sheath, that can lead to subluxation or dislocation of the tendon. You can have tears within one or both of those tendons. Not very common to have a full rupture, but you can still see the tears. Brevis sometimes has a low-lying muscle belly, so if they had a sprain and they kind of caught up into the ligament, and that can kind of cause a lot of irritation as well. Sometimes it's just a little bit of tendonitis at the os peroneum or at the fifth metatarsal base where your brevis tendon inserts. Mechanism: when the foot is inverted, results in rapid dorsiflexion. That's when peroneal tendons are more likely to get injured. As long as the tendon's not subluxating or dislocating, you can still potentially manage them non-op. I am a little bit aggressive in getting an MRI on these younger patients. Initially you can still trial non-op, functional rehab, all those options. If the tendon is dislocating and popping out and that is asymmetric, again, make sure you compare to the other side, because sometimes patients just have these hyperlaxity where the tendon's kind of popping in and out on both sides. If that could just be their normal. Some studies have shown that you can immobilize them in a cast. It really does not have a good success rate in my experience, and those patients are more likely to require surgery. Sometimes you can consider cortisone injection at the base of the fifth metatarsal for some of the tendonitis. But you can put them in a boot, you can immobilize them or use crutches or make it weight bearing as tolerated depending on what the situation is. There's a patient of mine, a 50-year-old female. She had an injury in January, was an ankle sprain. She had pain, some got better, but not all of it went away. Pain got worse in April. That's when she saw one of our PAs, got an x-ray, kind of saw that there is some issue with that os peroneum. On the x-ray, there was a little bit of, sometimes it just be patient's normal, but just looked irregular, and she was having a lot of difficulty. I got an MRI that pretty much showed that she had a peroneal longus tendon rupture. She had a complete rupture. She had a cavo-varus foot, meaning she had a high arch, so she was at a risk. So she probably had some underlying issues before, increasing her risk of getting a rupture. The reason why this is difficult to diagnose is because there's two tendons. So if one has a significant tear or rupture, they will still have motion. They will still have some strength, right? So basically it becomes important, like palpate. Important to figure out where patient's pain is, and they will have focal pain, not over the ligament, but definitely over the tendon just distal to the lateral malleolus. Cartilage injuries, these are some of the patients that need to be managed carefully. You can have lateral or medial talar dome cartilage lesions. Lateral talar dome is more common with acute injuries and acute ankle sprain. Usually they're superficial, they're smaller, but they're more symptomatic and they don't heal that great. Medial talar dome injuries, they're more common, but they're also more likely to be chronic in nature. So a lot of the times, if you're particularly, patients who are older, or if they had a prior history of ankle sprains, then it's possible they may have just had an old cartilage injury. Those patients palpate the medial, anteromedial ankle joint or medial joint line, right? A lot of the times you'll say that they don't have any pain there. All of their pain is located laterally. And those are the scenarios where, okay, you can say that this is likely old. And we need to just manage the ankle sprain itself. Injury, the mechanism is usually similar, but basically when the ankle is relocating back into the mortise, you get an impact on the cartilage, resulting in these flaps. MRI, always get MRIs on these patients. You need to make sure that they don't have any loose fragments and make sure that there is not any sort of large lesions that need surgical management. Sometimes it's not obvious on x-rays at all, so they'll get treated as an ankle sprain and eventually they'll get MRIs, and a lot of the times that's when we'll catch it. That's okay, not necessarily any harm done. Most of the times, they might have a little bit of worsening, but as long as they don't have any loose joint bodies and whatnot, they can still get better eventually. Manage a non-op early on, especially if they don't have any loose bodies. You can still manage them non-op, put them in a boot. You can make them non-weight bearing. Even though it says 50 to 60% success, I think it's a little bit better in my experience. And operative treatment, there's many different options, whether it's microfracture, ORIF if there is large fragments, or allograft, autograft. Don't need to go into detail for the purpose of this talk, but it's certainly treatment options. Surgical management is more likely, particularly when they have cartilage injuries. Syndesmotic sprain, also known as your high ankle sprain, right? So we talked about, again, when we refer to just ankle sprain, most of the time it's just we're talking about low ankle sprain. They're obviously the most common. So syndesmotic injuries are also important. Again, these patients need to be managed a little bit differently. This ligament's pretty low robust. It's a combination of your AITFL or your anterior inferior tibiofibular ligament, your PITFL, so your posterior ligament. And then you have your interosseous membrane and inferior transverse ligament. This anatomy is a little bit similar to forearm, kind of has similar protection in the forearm as well. Mechanism is more of an eversion sprain. If you look at literature, it can be anywhere from 1 to 18% of our ankle sprain can involve eversion ankle sprain, resulting in syndesmotic or high ankle sprain. These are longer recovery. They have residual symptoms. So just ask them what their mechanism was. Sometimes patients are not sure what exactly happened, but most of the time they'll be able to tell you whether they rolled their ankle in or out. And they can probably, if they roll their ankle in, it's really less common for them to have a high ankle sprain or syndesmotic sprain. Or if they do have some ligament issues, it's usually not to the extent where they're getting joint instability. When you're evaluating for these, again, location of pain is pretty important. They will have pain a little bit higher over the syndesmotic ligaments rather than your low ankle ligaments. There are multiple tests. We'll go over that on the next slide. Radiographs are important as well. Again, on x-ray, particularly if they're weight-bearing x-rays, you want to make sure you look at the tibia and fibula and the overlap between those things on x-rays. But unfortunately, these x-rays need to be weight-bearing, which help you a little bit better. In an acute setting, particularly when patients have had injuries, they're not getting weight-bearing x-rays. They're going to get non-weight-bearing x-rays because they want to make sure they don't mess anything up. So that's when, again, making sure if you exam is concerning of it, then need to consider weight-bearing x-rays. These are some of the tests. If you look at the top left in A, it's a cross-leg test. Essentially, that is a figure 4 position that pretty much results in resting the ankle. When you rest the ankle, that results in eversion, external rotation, and they'll start having pain over the syndesmosis. The length of the tenderness, right? Where is their pain? So just palpate the area of the syndesmosis, and sometimes that will tell you that pain is much higher up compared to your typical ankle ligaments. Your translation, grab the fibula, and then you can twist it back and forth, compare that to the other side. And if they have increased translation, that can be indicative of it as well. Squeeze test, squeeze the tibia and fibula proximally. What that does is gaps the distal portion of the tibia and tib-fib joint, resulting in pain. One of the easier one to do is E. It's just eversion, external rotation. So you dorsiflex the ankle and you externally stress them. They'll have pain kind of going up over the syndesmosis. They might have pain over the deltoid ligament. And so that can be done as well. And F, that's not done very commonly, but you can consider it in a more of a chronic issues. If it's not getting better, what we'll do is we'll wrap the ankle, syndesmosis up just above the ankle joint. And what that does is squeezes the tibia and fibula together, compensating for the ligament or the laxity that might be there. And we'll have patients do like a little bit of activities like jumping, standing on that leg and twisting. And a lot of the patients will say like that feels better than their normal. Again, simple tests that we can do that can be indicative of syndesmotic injury. These patients definitely need to be immobilized. As long as it's just an isolated ligament injury and there is no x-ray finding. If there is no instability of the joint on x-ray and it's just an isolated sprain, they can still be managed conservatively. Most patients don't need surgery. Unless you're high-level athletes, then you might consider it. Typically, they get treated in a boot for about 4 to 6 weeks. First few weeks might be non-weight bearing and then physical therapy. So you need to delay rehab for a lot of these patients. Some of the associated fractures, right? This is a patient. You can see like a small fragment over the lateral malleolus. You can see these are your avulsion fractures of the fibula. These are more ankle sprain than broken bones, correct? So I tell my patients, listen, you get treated more as an ankle sprain than an ankle fracture. They'll come to you because, from a patient standpoint, they're reading that they have a fracture on their X-ray report. But I tell them, listen, these fragments, they usually heal on their own. If they don't, you might just have an X-ray abnormality in the long run, but that typically does not cause long-term issues. The other thing I tell them is if they ever needed surgery for these issues, we don't fix the fragment. We take the fragment out and repair the ligaments. So that's more of an ankle sprain. If they have a lot of pain, again, can consider boot immobilization, but otherwise, brace, early rehab, all those things are appropriate for these distal fibular avulsion fragments. This is an interesting one. You can see on the X-ray on the left side of the screen, you can see there is a little bit of like a widening of the joint medially, not very obvious, but you can see there is a fibular fracture proximally. These are called Mason-Noonan fractures. Extremely important to diagnosis because patients sometimes will only complain about an ankle pain and the not proximal fibular pain. So if you're worried about it, always palpate for the proximal fibula. If you have a proximal fibular fracture with associated ankle pain, there's highly concerning of what we call Mason-Noonan fracture. These patients are more likely to need surgical intervention. They need orthopedic referral, and we need to make sure that they don't have instability. But most of the time, they do end up having, I shouldn't say instability because that's more ligamentous, but they'll have gapping of the joint on X-ray or on our stress X-rays needing surgery. This is another patient of mine, 48-year-old female who came to me about a few months after her ankle sprain. She was in the boot for a few weeks, did physical therapy. When we looked at X-ray, I only included lateral because that's the only important one. The other X-rays are not very obvious. You just see a couple of anchors into the fibula there, but nothing very obvious. When we get, she had an MRI done kind of showing it. This is a picture of the CT scan that I ordered after, kind of showing that there is a little bit of an anterior process calcaneus fracture. Most of these heal pretty well, right? So even when that gets missed, they can still have good outcome. And usually just rehab takes a little bit longer, but they're able to get back to their activities. Occasionally, these anterior process fractures don't heal that great and may need further intervention, whether it's ORIF or sometimes we just excise the fragment. This is where, again, physical exam becomes important because X-rays are not very obvious. The calcaneus, anterior process of calcaneus overlaps with other bones, so gets missed by radiologists, sometimes gets missed by orthopedic surgeons on X-ray. But they will have focal tenderness at the anterior process calcaneus or at the level of calcaneocuboid joints. If they're painful just everywhere early on, kind of similar to what I talked about before, putting them in the boot, letting it settle down for a couple of weeks, and then seeing them after, that's reasonable as well. And then a lot of process talus, again, that's extremely rare for ankle sprains. Simple. These are more like high impact, like snowboarders, things like that, those type of injuries. So we won't need to go into much more detail about it, but that's, again, something to keep in mind. So back to our low ankle sprain that we were talking about, when to refer to orthopedics. Again, obviously, if they're not getting better despite any conservative management, or if there is any concern of associated injuries that we talked about. What are the next steps? Additional imaging, stress radiographs, which again, we would obtain as orthopedics in clinic. Not everyone has that option depending on what we have available. MRI is a good gold standard as well for non-improving ankle sprain. Sorry about the back and forth, but this is a patient. You can see on the top left, when you do a talus tilt test, there's significant gapping at the lateral portion of the joint. On the right side, you can see when we do the anterior jaw test, there's significant gapping at the posterior portion of the ankle. Bottom left kind of showing what a normal and abnormal is before and after stress. So other options that can be done, ultrasound. The benefit of ultrasound is that it can be dynamic. It's very cheap to do, but the issue is that it's a newer skill, has a lot of learning curve associated with it. And in my hands, I am not very familiar with ultrasound, right? So we do have ultrasound in clinic, but really difficult for me to assess there is any tears or any sort of laxity on an ultrasound. Usually my exam is good enough whether there is laxity or not. MRI is gold standard in my experience. I personally, as orthopedic surgeons, most of us feel more comfortable with reading MRIs than we do with ultrasound. With ultrasound, we have to rely a lot on the radiologists themselves. MRI is expensive, obviously harder to schedule, but it's been well described in literature. And obviously you have the input of radiologist as well. Continued pain, even after conservative management, especially if you can be done early if you're thinking about peroneal tendon injuries, osteochondral lesions, or syndesmotic instability. So you can do MRI early on if you're worried about some of these associated injury that you might think change our rehab strategies. What are some other non-surgical options? PRP injections, that therapy has grown quite a bit, has a lot of interest, particularly in many areas of orthopedics. Very little literature kind of supporting PRP injections for ankle ligament injuries. There's some early pain relief. They compare PRP injections versus immobilization and rehab. They had the same results at 24 weeks, but had less pain at about 8 weeks. There's no difference in long-term outcome. If you look at other things, other biologics, such as bone marrow concentrates, stem cells, all of these things have no conclusive evidence. This is not something that I offer patients. We do PRP injections in our clinic for some other issues, but I've never offered patient PRP injections for lateral ankle ligament injuries. Again, just does not have necessarily literature supporting it. So let's talk about this patient of mine. He's a 32-year-old FedEx ground worker who had an injury in September of 2025. He continued to kind of work, saw me a couple of months after his injury, still had swelling, still had significant pain. There was definitely a decent amount of laxity on exam, just a generalized pain at the lateral ankle, not really able to localize particularly, but just a lot of pain. He did not have any significant treatment, right? But it's been 2 months. While I don't expect their pain to resolve without treatment, continued swelling couple of months after, particularly significant swelling, generalized pain. Those are things that I don't expect for patients. So I did get an MRI for that patient. MRI just showed ligament tears, your ATFL tear, CFL tear, had a sprain of the deltoid ligament. Did show peroneal tendonitis with possible tear, but not necessarily like a true rupture. So if there is like a longitudinal tear along the line of peroneal tendon, they will still have good function that can be managed conservatively. He did not have any conservative management, so we put him in a brace and then had him do a center for physical therapy. Unfortunately, he continued to struggle with physical therapy a few months, and eventually, without any improvement, he needed surgical intervention. We'll kind of just briefly talk about it. No need to go into too much detail about the surgical option, but again, they need to make sure fail conservative management. They need to have an instability, pain, or combination of both. Treatment options, typically we do ankle arthroscopy. We can do and then open procedure with ankle ligament repairs. Some people do arthroscopic repairs as well. You need to make sure they don't have any significant arch abnormality because that might need to be addressed also. So this is back to our patient, that 32-year-old FedEx ground worker. You can see on the top left, pretty significant laxity. On the right side, it's after, so left side is before. Same thing with the anterior aorta on the bottom, pretty significant laxity with anterior aorta before the repair versus after the repair. And obviously, not in a primary care setting, we don't really have the ability to do these stress x-rays or anything, but this is where we come into play, where you get referred to orthopedics. We can do these in clinic. We can do this during surgery as well to see how much work we need to do. So why does this topic matter? If you just look at the incident, pretty high incidence rate, and all of it is significantly underestimated, about 2 million acute ankle sprains on a yearly basis. Most patients don't go to the emergency room, right? Sometimes they show up directly to clinic, so not everyone gets included in these studies. There is a high number of emergency room visits. Majority of them are athletes. Like nearly half of those people who show up to the emergency room are athletes usually. It's a very common reason for missed sports participation, and particularly in basketball, it's a pretty common reason for missed game time as well. What about the workers? About 60% of the workplace injury involves musculoskeletal system. Foot and ankle injuries, about 10% of those, and majority of those are related to ankle sprain. So about 70% of those ankle injuries are actually ankle sprain. Patients who have comorbidities, so diabetes, thyroid condition, if there was litigation involved, particularly if there is coexisting injuries, had high cost claims. If they had only needed medical treatment, it was more $1,300, but when you combine with lost times, can be as high as $25,000. If they had coexisting injuries, however, those numbers were even higher, right? For medical treatment was about $2,400 per patient, and about occasionally mean average of 53,000 in lost times and lost wages. So Workers' comp patient also has a little bit, they have a higher rate of subsequent pain injuries than the non-working population does. We're not sure why, but whatever reason, there's been a bunch of literature that's been done in working population, and then certain areas where they do have a longer recovery compared to non-working population. Some of it has to do with the type of work they do, right? So some of that plays into it as well. But obviously, a lot of these costs, so definitely important for proper management in order to decrease cost, healthcare burden, and more importantly, getting back to jobs as early as we possibly can. So in summary, first line of treatment is pretty reasonable. Conservative management with physical therapy, bracing. Advanced has pain a lot. People ask me for how long. I say, it can be unpredictable. I give them general guidelines, but as your pain's getting better, you can gradually start doing more. There's no clear-cut guidelines on the length of conservative management. Watch out for these red flags that we talked about: syndesmotic high ankle sprain, cartilage injuries, peroneal tendon injuries, the Mason O fractures in particular. And, if any concern, you can refer them to orthopedics or get an MRI and refer them afterwards. I'm personally okay with either way, but depending on the orthopedic surgeon or the community that you work with, they have certain preferences, and always important to find those out. The only thing I did not mention is MRI does not always catch laxity. MRI will catch tears, MRI will catch that there is scarring. But if there is just laxity, and when the ligaments get stretched out, MRI does not know the difference between a complete normal ligament versus if it's a ligament that's stretched. So it may not catch laxity, but we still get MRI always to kind of rule out other injuries, see how much work we need to do. But I rely on my exam much more than MRI when it comes to laxity. And that's all we have. Any questions?
Thank you, Dr. Patel. That's a very, very helpful. For those of you who are in attendance, if you want to write in some questions, we can make sure Dr. Patel addresses those. But I can start off by asking you, for our purposes in the clinic, we often are dealing with the milder strains, and we sometimes get into disagreements over how long a person should use a typical brace. If they're gradually improving, do they need to brace until they're symptom free? Do you have any particular guidelines for that?
Yeah, they do not need to brace until they're symptom free, right? So what I tell them is, if it's a milder strain, don't need to use the brace inside the house. That kind of gives them a little more controlled environment. But I'll tell them, hey, if you're going outside early on, maybe just use the brace, particularly longer distances, longer errands, or uneven grounds, right? Maybe try to use the brace. And as you feel comfortable, you want to use the brace less and less because you don't want to become reliant on the brace either. You want to make sure eventually you kind of get back to your normal activity level. And then I'll tell them when you are trying to go back to some of the higher impact activities. So for athletes, when they're trying to go back to sports, maybe use the brace early on with practice. So I'll tell the workers the same thing. Maybe use the brace early on. And as you feel comfortable, you start using the brace less and less. Unfortunately, there's no clear-cut guideline, but sometimes some people are under the belief that, hey, if you're using the brace, you will lose your proprioception, and that's a downside in the long run. Not necessarily true. As long as they're working on their exercises, physical therapy out of the brace consistently, then it's okay, right? So but I definitely emphasize them, hey, as you feel comfortable, you want to make sure you start spending less and less time in the brace.
Excellent. One of our members asked about the PRP issue and what other indications do you use PRP for in your clinic?
In my clinic, I've done PRP for Achilles tendon. Really, that's the main thing that I've done it for. There is some indications for like some peroneal tendon injuries or mild tears and stuff like that in the younger patients, mostly in athletes. I get an MRI first to make sure like they don't have any partial tearing of the tendons and whatnot. You want to make sure that it's mostly like inflammation issues. And so Achilles tendon is usually pretty good. I have other partners who do more for rotator cuff issues. Some other physicians that do knee PRP injections as well. But from a foot and ankle standpoint, Achilles tendon is the main one that I've done it for. Peroneal tendon, I haven't done one yet, but there's an indication for that as well.
Excellent. Another question is, some of us shy away from the hard boots because of worry about the risk of DVT. And do you have statistics on DVT incidents in the boots, and how do you manage after they get the DVT and so forth?
Yeah, it's really low overall. I don't think exactly, but it's very low. Just in general, if you look at literature, for surgical patients, if you look at foot and ankle surgeries, there is actually no true indication that they need to be in DVT, that they need to have DVT prophylaxis after. These are the patients that are immobilized after surgery, right? So if we're putting them in the boot, if they have for a couple of weeks, that's usually okay. If they have risk factors, right? For example, if they have a personal history of DVT, or if you are concerned about it, you can just do aspirin 81 milligram BID, right? That's usually for my surgical patients. That's what I do. And that's what I'll do for patients who are in the boot as well. Particularly younger patients, that risk is really low. As long as they're coming out of the boot consistently, working on range of motion, that risk is significantly low. You just want to make sure you don't have, it's not just immobilization. And because for ankle sprain, you're trying to actually get them out of the boot, you're trying to get them to walk out of the boot, that risk is pretty low because they're constantly getting out of the boot, working on motion. Now, if they're having difficulty with weight bearing, so right, so it's not just that they're in the boot, they're using crutches, they're not walking at all. Those patients will be a little bit higher risk. So just doing aspirin, BID is very reasonable for the patients. If they do get diagnosed with DVT, depending on what it is, I will start them on Eliquis. I don't have the best experience in terms of like treating patients with DVT, so I'll eventually have them referred to vascular for how long they should be on. But usually they're below the knee blood clots. Again, a lot of them, they don't even need to be treated. But I'll just based on my experience, I'll start Eliquis typically.
Another question is what to do about the patient with the ankle strain who is starting to have paresthesias of their feet, of the foot.
Yeah, so it basically those paresthesias are usually a result of just a stretch of your superficial peroneal nerve. Those patients do need a little bit more care, like a little bit more immobilization. The problem is from a nerve standpoint, it's really difficult to predict how long it takes for them to come back. So, those patients are unfortunately a little bit higher risk of kind of developing CRPS as well. So you don't want to immobilize them for too long, but keeping them in the boot. But you actually realize that while they'll have it early on, they will start getting better as their swelling gets better. It stops pushing, it's pretty much the pressure on the superficial peroneal nerve decreases, and that actually starts to improve. So patients will start noticing that quickly as their swelling goes away. But if they're having significant paresthesias, kind of putting them in the boot, working on more swelling control and just gentle range of motion out of the boot at home, that's what I typically do. But if they're having consistent like nerve pain, as long as they have good motion and everything, the nerve pain itself is difficult to solve. You can consider doing like gabapentin for the nerve pain aspect of it. A lot of patients will find that helpful, but those are some of the options.
Do you put them on prednisone sometimes?
Depends on the swelling. Right, they have pretty significant swelling, and if I do that, then you can do like a steroid like taper, measurable dose pack, but typically not my go-to option. Most of the patients, in my experience, they will have those paresthesias early on, but as soon as the swelling gets better, it does resolve. It's not very common to have them consistently have long-term nerve issues, but it is a possibility. So those are patients that I will see them back in a couple of weeks just to make sure that that's improving.
Are there any other questions? I think another interesting concern is the issue of morbid obesity and these ankle strains. Do you treat them any differently?
No, really not. The initial options are still similar, right? Certainly, obviously, they may have longer recovery because of the weight that they have to carry, a little bit of higher risk of getting instability because their balance may not be the same, particularly if they're morbidly obese. But I don't treat them any differently. They might need brace a little bit longer, but you still need to start them with rehab and all those things.
Okay. Are there any other questions?
The only thing I think we didn't talk about was hyperlaxity. A lot of patients, if they have hyperlaxity syndrome, that's why whenever we looking for ankle instability, just make sure you compare your ligament exam to your contralateral ankle as well. Because you just want to make sure it's and in documentation standpoint too, you want to make sure like what it's like compared to the other side. Because when you document whether it's like mild laxity, moderate laxity, or severe laxity, again, becomes a little bit subjective, right? There's not really clear cut like what that means. So I document like, okay, compared to the other side, increased laxity is actually makes more sense because that means, okay, there's obvious clear abnormality compared to what their normal is. But just generalized hyperlaxity syndrome, they're more likely to sprain their ankle as well. You can look for any other hyperlaxity too, like Biden's criteria for hypermobility, all those things if they're not getting better.
Regarding people with the minor avulsion fractures, what is your feeling about us, the non-orthopedic folks, treating them sort of just like an ankle strain versus referring them immediately to ortho?
I think it's reasonable either way. I think sometimes patients don't feel comfortable with non-orthopedic managing them because for them it's like it's a fracture.
Yeah.
Right. And so if you feel confident, like, hey, listen, like this is just an indicative of a severe ankle sprain. That's what basically it is. I tell my patients, listen, this is a bad sprain and a very minor fracture. And so you get treated as a sprain. And that usually is like, okay, that makes sense. And, they kind of forget about the fracture because those avulsion fractures, sometimes they heal, sometimes they don't. Their X-ray might always look abnormal. But an orthopedic surgeon, I'm not going to change how that X-ray looks in the future. It's just going to look how it does. So, I think it's reasonable. I've had it both ways. I've had patients who get managed, by PCPs as a sprain, and then eventually they get referred. But sometimes patients just prefer that, to see an orthopedic because they see fractures on their report, and I think that's perfectly reasonable.
I think one thing that's complicating is that sometimes these little chips, they look sort of old, and you may not be
Yeah.
100% sure if they're really acute or old.
Yep. Yep, correct. And that definitely plays into it as well. And I'll see that on report as like potentially acute versus chronic. But when I see those x-rays, most of the time I'm able to tell on x-rays whether that's a chronic thing. But I tell them, listen, even if it's acute, don't, you still get treated as an ankle sprain. Like let's just say it just happened yesterday with your injury, right? We're still treating you for the ankle sprain, regardless of what that x-ray is.
Got it. We have a question about what about sport taping as an option for treating the ankle strain and immobilizing it?
Yeah, I think that's perfectly reasonable. And I think one of the studies kind of talked about just sometimes has a little bit of skin irritation from taping, so you just have to be mindful of it. But I think it's a very reasonable option. We do this a lot for athletes, right? Because using a brace inside the cleats is sometimes just not feasible. They just become so uncomfortable because cleats need to be tight already. So taping is actually less bulky, and they feel more comfortable with that. And I think that's a perfectly reasonable option.
That would be sort of reminiscent, I guess, to like double ankle strapping, which
Yeah.
I have found very acceptable in treating ankle strains, and the patients seem to like it because they can get their foot in their shoe easily and
Yep.
so forth. But
Yeah, no, absolutely.
any other questions? Well, I think that concludes our presentation today. Dr. Patel, thank you so much
Yeah.
for your time and talent on this issue, and we greatly appreciate this. So thank you, everybody, and we
Yeah,
can
thanks
conclude.
everyone.
Thank you.
Thank you.